So now let's have our case study about rheumatic fever and rheumatic heart disease. What do we have in this case? We have a 14-year-old white female who presents to the ER complaining of a very sore throat for 2 days, a rash all over, and chills, and the rash and chills developed within the past 12 hours. Sore throat, rash, and chills. In her past medical history, she had strep pharyngitis and severe rheumatic fever, arthritis, carditis, chorea at the age of 8, and she was treated with ibuprofen and penicillin. Family history: youngest sister also developed strep pharyngitis and rheumatic fever 6 years ago. Vital signs: her heart rate is 89, respiratory rate 16, temperature 101.8 degrees. Physical examination showed widespread scarlet rash on arms, legs, chest, back, and abdomen, widespread rash, moderate bilateral cervical lymphadenopathy, enlarged lymph nodes in the neck. Throat shows erythema, tonsillar swelling, exudates, vesicles. So, what is an appropriate diagnosis for this patient? Now, the most prominent feature is sore throat, and physical findings showed what? Exudate on the throat. We can diagnose this patient as having pharyngitis, and we do the rapid strep test, and we will know that it is group A streptococcal pharyngitis. This is the bad strain. This is the strain that is going to be followed 2 weeks later by some autoimmune reaction of the body towards an antigen in this bacteria called the M antigen, and by this same antigen, or a very similar antigen, is also found in the cardiac valves. So the antibodies 2 weeks after the strep pharyngitis will attack your cardiac valves, assuming that this cardiac valve is a bacteria. And this is how you get rheumatic fever following strep pharyngitis, group A streptococcal pharyngitis. So what are the clinical manifestations that are consistent with your diagnosis as strep pharyngitis? Here they are. Sore throat, of course, widespread rash, chills and high-grade fever, and the skin is very warm. So these are manifestations of streptococcal pharyngitis, and most important are the manifestations in the throat: redness, tonsillar swelling, exudates, vesicles. All are signs of pharyngitis, and the exudates suggest that the causative infection agent is a bacteria, not viral. Cervical lymphadenopathy, bilaterally enlarged cervical lymph nodes, elevated white blood cell count, leukocytosis, bacterial infection, positive latex agglutination test for group A streptococcus, elevated C-reactive protein. It's a non-specific acute phase reactant that increases in any inflammatory condition. Positive anti-streptolysin O titer, positive anti-streptolysin O test, very diagnostic for this group A streptococcal pharyngitis. Why can rheumatic fever be ruled out as a diagnosis in this particular case, in this particular incident? Because rheumatic fever occurs 1 to 5 weeks after a strep pharyngitis, and now the patient history is only 2 days. It's too early to diagnose rheumatic fever. And the patient has no major signs of rheumatic fever, which are critical to diagnosis. We're going to know what are the major signs to rheumatic fever. So, does this patient have any sign of rheumatic heart disease? Let's see. The patient does not have any chest pain. The patient does not have any murmur, any AKG changes. So she does not show any manifestation of rheumatic heart disease. No murmur suggests no valve affection now. No chest pain or rub suggesting pericarditis, no AKG manifestations. Most probably the heart has not yet been affected. What type of regular monitoring is necessary for this patient, and why is it required? Don't forget, the patient had previously severe episode of rheumatic fever with signs of carditis. This means that the valves might have been affected. So you need to follow her up by regular cardiac examination. And the heart murmur is the first sign of rheumatic heart disease. And the nature of this murmur is going to suggest that the valve is involved, what valves are involved. And if you hear a heart murmur, if you can detect a heart murmur by auscultation, you need an echocardiography, and this is going to verify the diagnosis. So always follow up these patients with a history of rheumatic fever, follow them up by cardiac examination, try to detect a murmur, and once you detect a murmur, verify it by echocardiography. What's the drug of choice for this patient now? Strep pharyngitis, penicillin. Strep pharyngitis, group A strep pharyngitis, penicillin, or macrolides, penicillin, or azithromycin, penicillin, or azithromycin. And we have been doing good job treating this strep pharyngitis with antibiotics, and this reduced greatly the incidence of rheumatic fever. Identify 3 major risk factors for rheumatic fever in this particular patient. From the patient's history, we know that there is a positive family history for streptococcal pharyngitis and rheumatic fever. The youngest sister also has been affected by this condition. This is a risk factor, and the patient has been treated for strep pharyngitis and rheumatic fever previously, and this is a risk factor for further rheumatic fever. And the poor personal hygiene and dress suggest that poverty is a risk factor. Poverty plays a role in poverty or limited access to medical care, and antibiotic therapy for pharyngitis also plays a role in the development of rheumatic fever.